This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
So to kick off today's program, I'm going to introduce Dr. Fries. I'd like to spend a little bit of time talking about every speaker. Dr. Fries, to me, is a consummate transplant surgeon, tireless worker who just loves operating and can't stop transplanting. And remember one time, he had transplant back to back to back, and he said, I'll be happy if I do 2 more this week. So, and he's also, one of our favorites in terms of being on call together for liver transplant inpatient service. And he's also very active doing research. He is a key member and a site PI for the NIH-funded A2ALL consortium on live donor liver transplantation. And Chris is going to enlighten us with the experience of A2ALL, what we can learn from the live donor experience. Chris.
Well, thank you, Francis. It's always a pleasure to get to hold the podium for a brief time. So I was putting together my slides, I realized just how extensive this research effort has been with the A2ALL group that, as Francis mentioned, I've been part of now for actually over a decade. And I'm going to try and go through some of our findings that have been, I think, the most significant findings over the last decade, and try and do this in 20 minutes. So hold on to your seats here. It's going to be a little bit of a wild ride. Okay. So for those of you who don't know, the A2ALL study is an NIH-funded consortium of 9 transplant centers. Originally, it also had funding from HRSA and the ASTS, and really was broken into 2 phases. The original study had 9 centers that had some experience with living donor transplant, and went from 2002 to 2009, and then beginning in 2009 was the A2ALL-2 study, which had 2 new centers, one of them being Toronto, which is probably the busiest living donor transplant center in North America. And really the purposes of the study were several. One was to look at outcomes of recipients and specifically look at some subgroups, patients with hepatitis C and hepatocellular cancer. And probably more importantly, at least when the study was initiated, to really try and determine the safety of this procedure for living donors. And of course, this was after the initial donor death in this country in New York. So I think the federal government got very anxious about making sure that this new procedure, which was very new at the time, is going to be safe for the public. And probably the most important piece of this, at least as I've watched the study go on for the last decade, is really to get into the long-term health-related quality of life in donors. So our initial efforts at studying this situation really involved collecting all of the 9 centers' experience up to the point of when the study first started in 2002. And we wanted to look at both the living donor recipient and donor patient populations and look at their morbidity and mortality, causes of graft failure, and also determine the importance of transplant center experience in outcome. So in the initial cohort, there were 820 patients who had transplants between 198 and 2003, and of those, almost 400 had received living donor transplants, so a fairly robust sample size. And we looked at a lot of different variables. Again, most of this was done with retrospective chart review initially. And you can see the experience at the different centers, which sort of mirrors what the national experience was, and the 9 centers represented about 1/3 of the activity that was going on in the country at that time in terms of living donor transplant. And the first thing that was very obvious was most centers were transplanting patients with lower Meld scores. You can see the great majority had Meld scores between 11 and 20. In terms of the graft characteristics at that time, which again we're talking the late 1990s, early 2000s, the majority of centers, almost all really, were doing right lobes and very good sized right lobes. So the issue of small for size syndrome, which was actually a fairly rare event in that early experience. And the first important piece of data that we got out of this review is that patient and graft survival actually were quite good, and we had follow-up at that point out to as long as 4 years. And really this is superimposable, at least in terms of patient survival, to a deceased donor graft. So that was reassuring that we were doing at least as well as deceased donor transplant. And things that initially fell out in this retrospective review as being factors associated with graft failure were most significantly recipient age at the time of transplant. Also, the center case number became a very critical finding in our early study, showing that centers that had greater than 20 transplants under their belt really had far superior outcomes. And this idea of the learning curve was really one of our important early messages. Not only was graft survival improved as case number increased at a given center, but individual complications such as biliary complications also improved. And this is shown graphically here. If you look at time to graft failure, and the yellow line is case 1 to 20, you can see the outcomes are less good compared to when centers had greater than 20 cases. And shown here in a little bit different graphic with hazard ratios, you can see across the bottom when centers reached case volume 21 and greater, the hazard ratio of living donor versus deceased donor actually fell below 1. So it was a superior operation once the center's experience was adequate. Once we had this initial sort of survey of how recipients were doing, we developed a very important study looking at the risk of death of transplant candidates if they choose living donation versus staying on the deceased donor wait list. And to do this study, we actually had, again, a cohort of patients that included not only recipients of living donor transplants, but also patients who had a living donor identified but never went on to have a living donor transplant. So patients who were enrolled in this study had several different potential fates. One is they could die on the wait list. One is they could receive a deceased donor transplant either before their living donor transplant was happened or later on in time. And then the third potential outcome is to receive a living donor liver transplant. And the question was is which of these pathways would lead to the best survival? And again, in this cohort of nearly 800 patients, some of whom received deceased donors, some who received living donors, and some who remained on the list, you can see that 23% of those patients died. So death on the wait list and even death from both types of transplants was still fairly significant. But the important message was twofold. One, the overall mortality in patients who received a living donor versus a deceased donor was similar. So the outcomes with transplant of these two types of transplant were essentially equal. More importantly, the living donor liver transplant recipients had a lower mortality than those who waited on the wait list for a deceased donor transplant. And again, this was a very important message suggesting that steering patients towards living donor liver transplant early on in their disease process made a lot of sense. And this is shown in a slightly different way here. If you pay attention to the bars to the far right, again, when centers had more experience, the chances of having outcome better or equal to living donor to deceased donor liver transplant if you had a living donor transplant were achieved, again, once the center experience was greater than 10. Subsequent to that, I think an even more important paper that I think sometimes gets a little lost in the literature was published by Dr. Berg as the first author, and this really focused on patients during the Meld era, since many of the patients that were in this earlier cohort were transplanted before the Meld scoring system was in effect and used for allocation. And there was certainly very good studies looking at deceased donor transplant and the impact of Meld score in terms of survival, suggesting that patients really only gained survival benefit pursuing transplant once their Meld score was greater than 15. Well, what Dr. Berg's paper showed was that living donor liver transplant actually improved survival even with patients with a Meld score less than 15. And I think this is a very important message when considering potential candidates. And again, the survival was also equivalent to deceased donor transplant in patients who had Meld scores greater than 15. So again, these early conclusions really show that living donor and deceased donor transplants had similar graft and patient survival, although clearly the patients that were receiving living donor transplant were less sick. And these results had some impact by the center's learning curve. And also novel finding in the early studies was that there was a potential benefit to patients who received living donor liver transplant, even with the Meld score less than 15. So the next phase of our study really sought to characterize the different complications that recipients of living donor liver transplant could experience. And again, we started by looking at our retrospective cohort chart review, comparing over 300 living donor liver transplants to over 200 deceased donor transplants, and a very detailed data collection. The study was designed in such a way so we could not only capture what the individual complications were, but also grade the complications for severity using a well-accepted Clavian severity grading system. Grade 4 complications are the worst. Those would be complications with either recipient death or need for retransplantation. And the things that became apparent when we looked at these two cohorts, the living donor and deceased donor transplant, was that the melded transplant of the living donor liver transplant recipients was again lower than the deceased donor liver transplant recipients. Again, they were less sick patients. And you're not going to be able to see this, but I'll take my word for it that the recipients of living donor liver transplant generally had a higher rate of technical complications. And biliary complications, as we hopefully all know by now, were higher in recipients of living donor liver transplant. In this particular study, it was 40% versus 24%. But also other technical issues, such as vascular thromboses, were higher in the living donor liver transplant recipients. Biliary leaks improved as center experience improved. We learned that trying to anastomose too many ducts probably didn't make any sense. Biliary strictures also seemed to be better prevented in patients who had roux anastomosis done. So this was a finding of this earlier study. In the subsequent years of the A2ALL study, we of course continued to accumulate patients, and a more recent review of recipient complications now included over 500 living donor liver transplant recipients. In this particular study, we excluded the learning curve effect by eliminating the first 20 cases at each center. And again, if you look at outcomes, clearly in these two cohorts, they're different patients. The deceased donor liver transplant patients, many more were in the ICU, many more had renal failure compared to the living donor cohort. And again, this review of this larger collection of patients, prospectively studied, again demonstrated that there is a higher chance of biliary complications, both in the form of biliary stricture and bile leaks in recipients of living donor transplants, and also vascular complications. In the recipients of deceased donor transplants, many of the complications of sicker patients were seen in the postoperative period, including ongoing problems with ascites, pulmonary complications, and other infectious complications. And if you look at time to resolution of these different complications shown graphically here, again, suffice it to say that across the top graphs, the complications of biliary stricture and bile leak were clearly much higher in living donor liver transplant recipients. One interesting finding in this newer analysis of recipient complications is that deceased donor liver transplant patients had a much higher incidence of chronic kidney disease that progressed to end-stage renal disease. And in fact, living donor liver transplants seem to be protective against this problem, again suggesting that if you can transplant patients who need a transplant sooner, you can help prevent some of the chronic renal disease that we see in patients who present much more ill. So we focused a lot on the biliary issues. There were separate studies looking at how many procedures patients have, living donor recipients have, since biliary complications happen more commonly. As you might expect, they do have more procedures overall. If you look at each of the individual scatter plots, the living donor group is on the right, deceased donor on the left, and clearly they had more percutaneous transhepatic cholangiograms. But if you looked at time to resolution of biliary complications, the curves were pretty similar between both deceased donor and living donor transplants. And we actually tried to develop something called the BMI, or Biliary Misery Index, since as any of you who've had a living donor recipient in your practice knows, that a lot of them have some tubes and drains that stay in for what seems like to be forever, but eventually these problems do resolve. So the biliary complications are higher, but they can be dealt with in the long run. Now, another important part of the study was looking at donor outcomes. And again, our initial experience was looking at a retrospective cohort. We had about 400 patients in this particular cohort. You can see the average age was about 37. Most of them were biologically related to their recipient. And if you look at donor hospitalizations, or rehospitalizations more importantly, about 86% of patients never came back to the hospital after their index donation, but there were some patients that had as many as 3 to 5 rehospitalizations. And the number of donors that had any kind of complication is shown here. Again, the major complications that would lead to need for transplant or death were fortunately very minimal in this group. And the overall complication rate was about 40% in the living donors, most of them being Clavian grade 1 complications, which are of much less severity. Now, what about donor mortality? Well, in the cohort that we initially studied, we had only one donor that passed away as a direct result of the donation. There were 3 other donors that had either an accident, a suicide, or a substance overdose. And really the conclusions that we could draw from this is that about a third of adult living donors will experience some complication after donation, most of them being grade 2 or less. The mortality question remains a little bit more of a difficult issue to establish, given the findings in our cohort, which showed a very low mortality rate. Now, again, living donation results were compiled prospectively as well, and we now have over 760 donors that have been followed for as long as 12 years. If you look at the overall complication rate, it's persisted through the 12 years or over a decade of this study. The interesting finding in this more recent review is that most of the complications resolve. So things like infection and bile leak do resolve within the first year, but the 2 that seem to persist and can increase over longer periods of time are incisional hernias and psychological problems. So that was an important finding from our longer-term study. So we also looked at the impact of liver donation on lab values, and we had lab tests at 1 week, 1 month, 3 months, 1 year, and then yearly for nearly 500 donors. And it's very clear that the liver tests return nearly to baseline in all the patients. The one thing that was very interesting was a lower platelet count in about 20% of patients, maybe reflecting some relative portal hypertension and hypersplenism. So that's an area of further study. And getting back to donor mortality, again, we had only one donor that passed away in the cohort. Although if you look at national and international statistics, the rate of potential death for a right lobe donor is about 0.5% and about 0.1% for a left lobe donor. And these national and international sort of cataloging of deaths is quite problematic. This was one paper that I looked at that actually reported a death in Northern California that I think was from a paper that we wrote at our own center that was misinterpreted, a line in the paper. So these calculations of international death rates are really somewhat problematic. But I think a rate of about 0.2% is probably in the ballpark. Now, what about liver cancer? This was also an important sub-study of the A2ALL study. We had about 150 patients who underwent a living donor liver transplant. Were in the living donor study, 73 of them getting a deceased donor and 49 who received a living donor. And importantly, the findings in our most recent analysis is that outcomes are very similar. The living donor liver transplant recipients tended to have higher AFPs, larger tumors, further stage of tumors at the time of transplant. And as you might expect, that translates into a greater chance of recurrence. And of course, on explant pathology, the clinical findings were confirmed that the living donor recipients had larger tumor nodules. The overall recurrence rate was about 20 in 122 that were transplanted. But if you adjust for tumor stage, vascular invasion, other clinical features of the tumor, there's really no difference in tumor-free survival between living donor and deceased donor. So this was, again, another important finding. Predictors of HCC recurrence were pretty much what you would expect: larger tumors, vascular invasion, and patients with more nodules on their explant. Another important area that was studied extensively was the impact of living donor liver transplant on hepatitis C progression. When this study first started in the late 90s and early 2000, there was a lot of debate in the literature about the impact of living donor on hepatitis C progression. And some papers clearly concluded that living donor liver transplant patients who have hepatitis C do far worse than somebody who receives a deceased donor graft. So this was a very important area of study. And again, we had a large cohort of patients that we could look at. We excluded patients who had been treated and had sustained viral response. So we wanted to look at the natural history of patients who have hepatitis C at the time of transplant. Liver biopsies, which had been obtained post-transplant at regular intervals, were read centrally. Additionally, there was an advanced disease form or clinical assessment of recipients to try and determine if clinically they showed signs of cirrhosis. And if you look at the time to advanced disease based on histology, again, no real difference between living donor and deceased donor. So this was a fairly solid bit of evidence that really hepatitis C patients do not do worse if they receive a living donor liver transplant. And if you throw in the clinical assessment, again, the predictors of fibrosis were not any different between living donor and deceased donor. So in terms of these select groups, there were equivalent outcomes of deceased donor and living donor for both HCC and hepatitis C. The role of living donor liver transplant to allow for a strategy of pre-transplant hepatitis C therapy was a very exciting avenue of research when the therapy was interferon and ribavirin and potential for decompensation. Also the possibility that a recipient would get a younger graft in the living donor setting seemed to make sense to steer patients towards that direction. Now that we have the new drugs, it's a little harder to say where that's all going to go. So that's what we've learned. I think the key messages, what I think we'll be hearing more about from the A2ALL study are some psychosocial outcomes and health-related quality of life outcomes in the donors. So how well we do with their pain control, there's going to be a nice paper coming out on that, and then several very nice papers on the health-related quality of life. In this newest A2ALL-2 study, there were 2 centers that individually called donors to gather information on their health-related quality of life. And once that data is analyzed, I think we'll have a real good look into the psychosocial aspects of the donors. And this is just some preliminary work that was reported at the World Transplant Congress. You can see that about a quarter of donors have concerns about their general health. So this is a very important area of research. And I think of all the things I've seen determined as we've studied living donor liver transplant, this is probably the most provocative, in my opinion. So what do we not know after a decade of study. The idea of the upper limit of Meld at which a patient can safely undergo living donor transplant. Currently, the word on the street is 25, but can that be pushed? If you look at national statistics, looking at UNOS data, clearly patients who undergo a living donor liver transplant when their MELD score is greater than 30 have inferior outcomes shown in the lower curve. The patients that get a living donor liver transplant with low MELD have superior outcomes. But in between, patient outcome is quite reasonable. And if you look at individual center experience, the same trend seems to hold. Once you get up to MELD scores over 30, the outcomes are less good. But it does suggest that we could push the envelope in terms of MELD score up to about 30. What about left lobe versus right lobe? The great majority of these patients underwent right lobe transplant. At UCSF, Dr. Roberts and Dr. Asher, the surgical leaders of the program, have been real pioneers in the use of left lobe for transplant. Probably a safer operation for the donor, a little bit more risk for the recipient. And what is the impact of portal inflow modulation? Again, these are all active areas of study. You can see our center's experience here. The recent transplants in the red have primarily been left lobe, so we generally prefer that, all things being equal. And our results are really quite excellent and certainly comparable between the two types of grafts, looking at 1-year survival, the left lobe 88% and 90% for right lobe, and these nearly similar results are maintained out to 5 years. And similarly, patient survival at 1 year, 3 year, and 5 years is also excellent for patients that receive a left lobe. What else don't we know? We don't know what the upper age limit might be for a donor. Any of you have been paying attention to our donor criteria have probably noticed that over the last decade we've gone from a limit of 50 to 55 and now it's 60. I just read a report of a center that did a donor at age 76. So how high can we go is an unknown. And lastly, and probably most importantly, after a decade, can we stand back and answer who are the ideal patients? And we argue about this all the time when we have our NIH meetings. How are we going to increase living donor liver transplant case volume? The volume has remained fairly stagnant over the last decade, despite many papers showing the advantages of living donor. And how do we best inform patients and outside referring physicians about these complex decisions? And here graphically is shown the number of living donor liver transplants over the last decade. You can see the spike up to almost 400 just before the A2ALL study started, and it's been fairly stagnant since then. The number of centers that are doing more than 10 transplants is fairly limited. In 2013, there were only 7 centers nationally doing more than 10 transplants. So again, it hasn't caught on the way the studies that we have done suggest that it should. So in summary, I think we've learned that living donor liver transplant is an excellent option for a select group of patients. The outcomes certainly parallel and in some cases are superior to deceased donor transplant. The donor operation obviously has risk, including some mortality, very limited mortality, and some long-term morbidity. And fortunately, there's still a lot of room for more research and technical advances. So I think it's a very exciting field, but it is an option for our patients that I think is only going to grow in the future. So I think I'll stop there. All right, I guess.
That's great, Chris. Any questions for Dr. Fries? Can I put you on the spot
Sure.
a little bit? If we assume that the benchmark for survival at 5 years for diseased donor transplant is about 70%, what do you think is the survival threshold you would, say, put for life donor transplant? Can we lower that threshold for life donor transplant in terms of 5-year survival?
No, I think it would have to be at least equivalent. You know, again, the patient populations are a little bit different, but I think in realistically talking to donors and recipients about the risks they're about to go through, I think you have to be able to offer them at least equivalent results to the other option of deceased donation. And of course, the other piece of this is death on the waiting list, and that's an area where living donation has the potential to do much better than waiting for a deceased donor organ, especially as allocation rules change, which you're going to hear about in a minute.
So the question is, do you think that we can expand the criteria, say, for HCC in the live donor transplant?
Well, you want to bring me back to the debate I did a couple of years ago. I think, you know, it's being done cautiously already, but I think there has to be limits. We don't want to overdo it and suddenly be doing transplants with far inferior outcomes. And certainly pushing the limits with cancers is something we're already doing, but with some careful guidelines.
Rio?
Right.
Zero.
Right.
The only ones that occur actually in this country are in areas where the Meld score is pretty high.
Yeah.
Do you think that the current environment justifies doing living donor transplants in all those other areas?
Well, what I like to think about is the analogy with kidney transplant. In kidney transplant, living donor makes a lot of sense, not only because you can get your transplant when you're healthier and not have to wait many years on dialysis, but the quality of the graft is far superior. And outcomes, if you look at graft half-life, are far superior. Making that same jump to a living donor graft is a little harder to do. I think the grafts are probably equivalent at best. So what you're really looking at is trying to decrease weightless mortality. And in areas where you have access to a deceased donor transplant, I don't know that it makes sense to pursue living donor transplant because of this graft quality issue. But obviously in many other parts of the area, ours being one of them, where deceased donor transplant requires a Meld score in excess of 30, the real role of living donor transplant is to try and prevent your patients from getting to that point. And in an ideal world, you would save deceased donor transplants for the patients who have become the most ill. Okay, thank you.
Thank you. That was terrific.